Okay, well, good evening. I think we will get started, and I would like to welcome everybody to this virtual session. Tonight, we will be hearing about two experiences that will be shared on cases of COVID-19 and HIV from the Kingdom of Bahrain, and we'll be hearing also about challenges faced by people living with HIV during the COVID pandemic from Beirut, Lebanon. The objectives of the meeting are clear, but I would like to first point your attention to the interpretation. So there is simultaneous interpretation for the session from English to Arabic. Well, Arabic is listed as Japanese there, and English to French. So please select your preferred language if you prefer to hear this meeting simultaneously interpreted and translated to Arabic or French. للي بحبوا يتابعوا هالبرنامج باللغة العربية أو باللغة الفرنسية بدي ألفت نظركم إنه الترجمة فورية متاحة. إذا بتطلعوا على الكعب الشاشة مطرح ما مكتوب interpretation وبتكبسوا هونيك فيكم تنقوا جابانيز العربي، اضطرينا نحطه جابانيز بس جابانيز يعني عربي، وفرنش للي بحبوا يتابعوا البرنامج بالفرنسي، ترجمة فورية من الإنجليزي للفرنسي. I will go back to listing the objectives of the meeting, which are to discuss challenging cases from the MENA region and to highlight issues related to HIV management, medical management complications, as well as to share interesting aspects of the care continuum and identify barriers and challenges and potential solutions. So a few words on housekeeping rules, please. Then all the attendees are muted. And as I said, we have simultaneous interpretation, الترجمة الفورية من الإنجليزية للعربية والإنجليزية للفرنسية. En même temps, traduction en temps réel de l'anglais en français est possible. Vous pouvez suivre le curseur, vous pouvez choisir votre langue ici en cliquant sur interprétation, et vous pouvez choisir anglais, arabe, japonais. Vous voyez japonais, mais c'est arabe et français si vous préférez. I will continue in English. I would like you to feel free to send in your questions for the speakers at any time through the Q&A box here. And you will notice that there is also a thumbs up icon when someone will ask a question. In the Q&A, if you have a similar question or find this question important, please use that. In case you're having an issue with Zoom, you can find additional guidance provided in the chat box, please. So go check the chat box if you're having issues with your connection or Zoom. We have planned 2 Q&A sessions tonight after each presentation. So please send in your questions to the Q&A box. And if it is for a specific speaker, please specify that when you type in your question. And also you have the option, if you will, to send questions to the IAS team at the email iasedu@iassociety.org. We encourage you to all share your name, organization, country, and email address in the chat box so we can exchange contacts during this session, enhance our network, because that's the point. Our point is to enhance this network from around the MENA region to reach out to experts and people involved in HIV care so that we become a network, we become connected, we can talk, exchange expertise, ideas, resources to empower our providers and people living with HIV in this part of the world. There's also an announcement about membership. So there's a special membership offers that will offer you a discount to you as a participant of this meeting to become an IAS member. So look at the slide on the screen for more information. And you can get 6 months of free IAS membership, which is great, just by participating tonight at our meeting. And without any further delay, I'm going to introduce my co-host, if you will, Dr. Arash Alaei, and we will. I'm happy that he is here with us. So Dr. Alaei is a moderator for this first half of the session. And Dr. Alaei is a co-founder and a co-director of the Institute for International Health and Education in the USA. Currently, he's a senior advisor for the Tajikistan Ministry of Health, supported by the US CDC. He's been an activist and worked a lot on HIV issues and involved in HIV himself. So Arash, without any further delay, the floor is yours.
Thank you very much, Dr. Rizk. It's my pleasure to introduce Sarah Abuzeki, who will present on challenges faced by people living with HIV in Lebanon during COVID-19 time. So Sarah Abuzeki is a project manager at Marsa, a sexual health center in Beirut, Lebanon. It was my pleasure to visit amazing work they did in that facility and organization in Lebanon. Her work is focused on supporting advocacy activities and generating research on the sexual health of women and LGBTQ individuals in Lebanon. Her current position and past experience at the National Mental Health Program and the American University of Beirut Medical Center have helped shape and reinforce her firm belief in health equality and the importance of inclusion in health. She holds a master's in public health with a concentration in epidemiology and biostatistics. It's my pleasure to introduce Sarah, and Sarah, floor is yours.
Hello, everyone. My name is Sarah Abuzeki. I'm a project manager at Marsa Sexual Health Center. We're located in Beirut, and I'm happy to be presenting to you today as part of the HIV/AIDS MENA network first virtual session. Today, I'll be talking to you about the impact of COVID-19 as well as other multiple crises that we've faced here in Lebanon in 2020 on the mental health of people living with HIV. So in brief, the year 2020 was very difficult for people living in Lebanon. In addition to the pandemic, we've also had political uprisings that started in 2019 and continue to today. We've had an escalating economic crisis, perhaps the worst in the history of Lebanon. We've also had a very devastating explosion in August that destroyed a big portion of Beirut. Cost the lives of around 200 individuals with many, many injuries. We're also part of a very fragile geopolitical climate that's affecting the region. And so if we're going to talk about the impact of COVID-19 on the mental health of people living with HIV here in Lebanon, we can't isolate the pandemic from the other crises that are happening, because they all sort of come together and exacerbate the challenges that people living with HIV are facing. So in short, people living with HIV, most of whom are members of the LGBTIQ community here in Lebanon at least, continue to face stigma that is associated with their gender identity, sexual orientation, or their HIV status. In fact, a study that was published in 2020 that looked at the quality of life of a sample of people living with HIV here in Lebanon, and this is pre-2020, so the study was conducted perhaps early in the year or late 2019, so before COVID-19. So the study found that experiencing stigma and discrimination is correlated with a lower quality of life for people living with HIV. Also, the domains concerning mental health and financial status scored the lowest among people living with HIV. And the most significant determinants of quality of life were more of psychosocial aspects of life, such as social relationships, but also mental health. So clearly, the mental health of people living with HIV is quite affected by the experience of stigma and discrimination in Lebanon. So at MERSA and in collaboration with UNFPA, we launched a survey to help us assess the impact of the Beirut explosion on LGBTIQ persons on multiple fronts, one of which is their mental health as well. And the reason why I wanted to show some of our preliminary results was because, as I mentioned earlier, a big set of people living with HIV here in Lebanon are from the LGBTIQ community. And so in that sense, there's a lot of commonality between two populations. So the sample included 109 individuals. When they were asked about their main concerns, many of the participants were very concerned about the food prices in Lebanon, about their personal security following the explosion, of course, exposure to COVID-19, and their ability to earn an income. When asked about what they believe are barriers prevent them from accessing mental health services, the most cited barriers were, of course, the high cost of these services and the fear of being stigmatized when accessing these services. So 42% of this sample found that access to sexual and mental health services were further obstructed due to the blast. When asked about a number of sort of not symptoms, but experiences that they might have went through following the explosion, we find that the vast majority of the sample have experienced and also continue to experience physical or even emotional distress. As you can see from this graph, a really big part of the sample have persistent negative emotional state, they have problems sleeping and concentrating. And if they don't receive appropriate mental health support, this could have a lasting impact on their well-being. So we wanted to share with you a couple of cases of people living with HIV who have received psychosocial counseling at MERSA during 2020. We will be talking about Maha. Of course, Maha is a pseudonym for privacy reasons. She is in her mid-20s and she identifies as a lesbian. Maha discovered that she was HIV positive while she was being hospitalized for tuberculosis in late 2019. Because of her TB status, she had to spend 8 months in isolation at the hospital and was in critical condition for a while. That's when she started receiving psychosocial support from our counselor. Of course, this period of isolation and her deteriorating health at the beginning had an impact on Maha's mental health. She required a lot of support, especially after losing her job during her hospital stay. She required support to regain self-confidence, to be able to re-enter the job market, which she did once she started getting better. However, due to COVID-19, regulations, government mandated lockdowns and so forth, she lost her job again. However, she is now in relatively good health and is undetectable. So that's great. She continues to struggle with a number of issues, which we will be talking about in a later slide. So another case that we're going to be discussing today is about a homosexual couple and we named them Sami and Danny. Sami tested positive for HIV while he was in a relationship with Danny. He required a lot of psychosocial support to be able to disclose his status to his partner, which he had received at MERSA. After that, he was able to tell his partner about his HIV status, and then Danny got tested and he was also positive for HIV. And since then, they've been receiving couples therapy at MERSA. They are both students. They're young, in their early 20s, and they have very limited income. They lost their jobs during, the multiple crises of this year, which has forced one of them to move back to his abusive family. And when he moved back, his family discovered his HIV status and his sexuality, which resulted in him being kicked out of the house. And of course, this has a big impact on his mental health and his well-being. Currently, Sami and Danny Danny are undetectable, which is great, and they're living together, but they still, they're very vulnerable to the precarious situation here in Lebanon. So, based on observations of our psychosocial program, we've been able to identify some main challenges that people living with HIV have been facing in 2020. Most prominent challenge would be difficulty in accessing their basic needs, so livelihood needs such as housing and food. This is a big concern for people living with HIV, and it definitely has an impact on their mental health and well-being and their ability to access services that they need. Also, they've been having limited mobility during 2020. This is due to the economic crisis, but also due to physical distancing and other government-mandated lockdowns, etc. All of this has affected their ability to engage in social activities. And for people living with HIV, who again are mostly from the LGBTIQ community, they might not have familial support. They might rely on community members or their partners, their friends for social support. And with the restrictions on their mobility, it has impacted their ability to receive the support and to engage in social activities. And this has had implications on their mental health. They also, especially at the beginning of the pandemic, there has been limited access to information regarding vulnerability of people living with HIV to COVID-19 and the effect of being infected with COVID-19 if you're someone who's living with HIV. So clearly at the start of the pandemic, there wasn't a lot of information available, and it was difficult for people living with HIV because they were quite concerned and they communicated their concern. And this was also, this comes sort of in addition to the fact that in Lebanon, we're very lucky that we have a network of HIV specialists that are very involved with their patients, and they've had always like a good solid line of communication with their patients. However, during the pandemic, especially when the number of cases started to increase in Lebanon and in other places, ID physicians were, as was the entire healthcare system, were overwhelmed. And this might have affected the line of communication between people living with HIV and their physicians. And this contributed to additional stress on people living with HIV. Of course, a lot of them experience long periods of isolation, which could be very difficult. There was also a reduction in the supply of HIV treatment. So originally in Lebanon, people, of course, can receive the HIV treatment for free. Usually they get 2 months supply. However, especially after the explosion, which destroyed the office of the National AIDS Program, they had to reduce the amount of treatment provided to 1 month's supply. So people living with HIV had to get their treatment on a monthly basis rather than every 2 months. And this was, of course, a bit difficult considering the limited mobility in 2020. However, also it may have contributed to a sense of anxiety, especially since people in Lebanon don't really trust, the government, and are always concerned that medication can run out or won't be accessible. Additionally, PHIV are still required to pay for their viral load, which they need to do regularly in order to renew their treatment. And with the current economic crisis, that's it's quite expensive, and not everyone will be able to afford it, and this would affect their ability to renew their files at the Ministry of Public Health. And of course, as we saw the story of Danny and Sammy, and also unfortunately even in the medical system, there's still stigma when it comes to HIV status, and people living with HIV still struggle with this stigma. So we've developed some recommendations that we believe can help support the mental health of people living with HIV, especially in these very unique and precarious conditions that we're living in right now. So for short-term and direct action, we definitely recommend supporting the livelihood needs of people living with HIV. This includes financial, housing, or food aid. This also can include, subsidizing or providing completely for free the routine tests required for them to renew their treatment. Also, it's very important that we improve access to structured information regarding COVID-19 and HIV. By structured, I mean that it is understandable by lay individuals who are not part of the medical field, that has practical information and steps that they can take in order to protect themselves or in order to know what to do in case they have COVID-19. And of course, it's a big need right now among, the Lebanese population in general, but also definitely for people living with HIV, is to expand funding for mental health and social support, because it's quite important. As we mentioned earlier, it's also important to support PLHIV with, telling their partners and asking their partners to get tested, but also so that they can take their treatment on time and respond better to their treatment. So it's definitely very important to improve access to mental health and social support by increasing funding to these otherwise expensive services. We have some recommendations that require more like long-term action, but that are also very important in order to improve the well-being of people living with HIV. And these include improving access, of course, to non-stigmatizing medical services. This could also mean improving access to HIV treatment supply, increasing the supply from 1 month to multiple months, so they don't have to make several visits to the center where they collect their treatment. Also, it would be very important to expand the local network of HIV specialists. As I mentioned, we have a number of great physicians who are currently HIV specialists and supporting people living with HIV here in Lebanon, but we really do need to expand this network. As we saw with COVID-19, we really don't know what's coming next, and we need more support for people living with HIV. And of course, we need to continue to expand advocacy to public and private institutions to include, or for better inclusion of people living with HIV in the workforce, because currently it is very difficult for them to find jobs, especially with a number of institutions requiring an HIV test prior to signing the contract or to employing individuals. And this subjects them to, discrimination when it comes to the job market. And this is it from me today. This is my contact information if you'd like to reach out, and I'll be happy to take your questions. Thank you.
Thank you very much. First, let me congratulate you and Mirza for amazing job during this, COVID-19 outbreak and, unstable situation in Lebanon. So I highly appreciate it. Your finding was amazing, and it's best for us to learn how you continue your job. So let me start with one question. Based on your survey and experience, what is your suggestion when we see, for example, disease such as COVID-19, outbreak of COVID-19, and healthcare worker will be super busy with the other job? What is your suggestion to continue care for, people living with HIV/AIDS or other, people who need, extra service, who need support? What do you think, and what's your suggestion for us?
Thank you, Dr. Arash, for this very important question. Actually, a lot of what talking about since the outbreak and since the start of the pandemic is the resilience of the healthcare systems across the world. And this pandemic, if it had one positive side, not exactly positive, but at least it let us see the gaps in our healthcare systems. And this applies, of course, to HIV care. So it's very important that now, as hopefully we recover slowly from this pandemic, we need to be able to address all of these issues. We need to make sure that if another pandemic arises, that people who require support for other conditions or other chronic diseases do not fall short from the support. When it comes to people living with HIV, it's very important to have social support. Now, unfortunately, like in Lebanon, the social support comes a lot from their ID physicians. This is not very common, perhaps, in other parts of the world, but because HIV is still very much stigmatized, people living with HIV might prefer not to confide with their status to other people. They like to limit it to either people, for example, that they see at MRSA or similar organizations, and of course with their ID physicians, whom with they become very close and they refer to. So to avoid this in the future, it would be very important to expand the network to include also perhaps social workers who might not provide support in terms of treatment and medication, diagnosis, etc., but they can provide the social support and they can serve as a point of contact with the physician in case later on the physicians do not have time for a different reason. So it's very important to expand this network. It's also information is very important. Now, clearly, at the beginning of the pandemic, no one knew what the implication of this virus would be on people living with HIV. But it was always important to have information from reliable sources that can allow the people living with HIV to understand better how this new virus could potentially affect them and what they can do to protect themselves. So hopefully next time when we are faced with a new hopefully not in the near future, but if we have a new virus or a new concern that's affecting us globally, we would be able to provide information that is structured and clear at an early stage to help people be able to take better care of themselves.
Thank you very much for your comprehensive answers. There's two questions. Number one, our participant wanted to know more about MRSA. And the second question is it possible that due to the economic crisis, the National AIDS Program in Lebanon would not be able to secure the medication? This is two questions, and it will be great if you can share more with us.
Of course, of course. So let me first address the second question. So far, treatment has been available for people living with HIV. The only thing that happened was that instead of 2 months supply, they only provide 1 month supply. There is no indication that the treatment will not be available in the near future. However, because we live in Lebanon and everything is, especially this year, everything was unpredictable, it's quite natural that people will be concerned, especially people living with HIV who rely on taking their treatment to be able to maintain their health and their well-being. So far, there is no indication that there won't be treatment available. However, it's understandable if people are concerned about this, but inshallah, as we say in Lebanon, that won't happen. About MRSA. MRSA is a sexual health center in Beirut. We provide comprehensive sexual health services, including voluntary counseling and testing, also medical consultations and psychosocial support. We provide awareness sessions and one-on-one educational sessions on prevention of sexually transmitted infection, contraception, communication with sexual partners, and consent. We also collaborate with academic institutions to support and improve sexual health education for current and future healthcare providers. We work on research. We published our first peer-reviewed article last October, and we're hoping to publish a new article very soon. So, of course, the network will be aware once this is published, and we will share it with all of you. We also work on campaigns to break the stigma when it comes to different topics relating to sexual health, including HIV and condom use, but also other topics such as being transgender individual in Lebanon, what are the challenges they face, or misconceptions regarding the period, and a range of other topics, which we aim to not only be informative, but also try to spark a discussion, start a discussion, so that hopefully in the future we can normalize sexual health and it can become just a part of our health continuum, and not a sensitive topic as it is right now in Lebanon and the region. And that's in short what we do at MERSA.
Yeah. Thank you. Again, I want to thank you and MERSA for your amazing job. I visited, their facility, and, it's fantastic. So let me welcome Dr. Ali. He has a question for you. How frequently should patients test their HIV viral load in order to receive their ART? Did you consider advocating for relying on other measure of adherence to ART than HIV viral load? At least actually, for select patients with long-standing viral load suppression. Thank you, Dr. Ali.
Thank you for this question. Actually, this is an ongoing discussion and a point of advocacy that we have been making with the program. I mean, especially if you can't afford to do this test and you can't receive your treatment unless you do it, this really puts the individual at a difficult place. And as I mentioned, advocacy is moving forward as organizations, as well as HIV specialists in Lebanon. We are asking for this requirement to be adapted to better accommodate people living with HIV. But unfortunately, currently, it's still the case. And how frequently? I think, if I'm not mistaken, and I'm sure Dr. Rizk can correct me if I'm wrong, they need to renew their file every 6 months to a year, and that's how often they need to do their regular tests.
So this,
yes. please, Dr. Rizk.
I mean, this is an important question. I think it's the National AIDS Program, recognizing all the issues and the problems we've gone through, is only requesting 1 viral load per year. And unfortunately, if I'm reading the question correctly, Dr. Ghalib, currently we don't have any other measures to rely on adherence other than the visits to the medication dispensing center. Most patients, for example, in Lebanon receive their medications through the National AIDS Program. So this is where they go, and if they miss an appointment or if they're late, somebody will call them, and if they cannot reach the person, they will contact us, the providers, to say, your patient is late, what's going on, what's happening. So that's another way we're basically trying to make sure people are okay and taking their medications.
So in addition to Dr. Nesrin, point, so our experience in Tajikistan, because we had limitation of, test and budget. So we categorized them in 2 groups, those who continue care and they wanted to continue and receive treatment. We changed the plan for adherence, and we don't do 6 months or yearly verse. So based on needed, we do that. But for complicated case who need more, so we continue the previous, plan. So the next question is, where can we get information about how the COVID-19 may affect people living with HIV/AIDS where access to ID physicians is limited? I think this is question for Lebanon.
Yes.
Yeah, but maybe we'll answer this question with Dr. Jamila, because this is actually what she will be talking about.
Yes, sure. Can I just give?
Sarah, yes, please.
Yeah, just from our experience at MERSA. So since the start of the pandemic, we got a lot of calls from people living with HIV telling us their concern. And what we did as an organization is we tried to provide them with the support that they needed. We tried to stay up to date, obviously, with all the new findings when it comes to COVID-19 and its implications on people living with HIV. And we try to provide them support as much as we can. So a good place to turn to if if physicians are busy or they're overwhelmed, would be organizations that provide services and support to people living with HIV.
Thank you very much. Because we have other presentation, I wanted to finish this part of the presentation and thank Sarah for her great experience and program at MERSA. Nasreen, we are with you.
All right, and so we have a poll at this time. I think you can see the poll, right? And I was, there are a lot of questions to me in the chat box. I'll try to answer them by typing. And here we go. So we have a poll now. I think it'll take a few minutes to answer the questions. Okay. And so while you're finishing, everybody's responding or taking a minute to answer the poll questions, I will go ahead and going to go ahead into the second part of our session this evening. And it is my pleasure to introduce my friend and dear friend, Dr. Jamila Salman from Bahrain. And she will be presenting us a case on perspective from the Kingdom of Bahrain tonight. So Dr. Jamila is an associate professor of the Arabian Gulf University and a consultant in infectious diseases and a consultant in geriatric medicine. She's also the chairperson of the Secondary Care Committee for Geriatric Care, chairperson of the HIV management team, chairperson of the Antibiotic Stewardship Program, and chairperson of the National Antibiotic Stewardship Committee of the Ministry of Health in the Kingdom of Bahrain. Dr. Salman has previously headed the Infection Control Committee in the Ministry of Health for 5 years and is the head of infection control in King Abdul University Hospital. So the floor is yours, Dr. Jamila.
Thank you so much. Thank you. It's my pleasure. Thanks a lot for the kind invitation. And the topic I'm going to talk about today, and I think it's probably important, and one of the questions has been raised, is the case of HIV and COVID-19. We all know what we've been facing. The whole world is facing the COVID-19 pandemic, and really the response to it and what aspect of our life has been affected. It's a lot. We are talking about the social. I think the previous speaker mentioned how it will be affect our, even the details of even the sexual life, how our health, sexual health is affected, the economy, the whole thing, our kids' education, how we are going around, how we are living our life. It's really affected all aspects of our life. And and I know that everybody is monitoring these numbers every day, probably some of us every hour, just to see what's happening. Initially, I remember the first few days we were talking about a couple of cases and hundreds of cases in China, and now look where we reached, and it's more than 70 million are affected. So it's a pandemic that we didn't experience within the last couple of decades, but that's what we were trained all the time as infectious disease to deal with it. But when it came, actually it hit hard, and we tried to do our best. So, when we talk about HIV and COVID-19, there are several principles, and we have to get back to the basic. So the basics of ART and when should start, and we have to continue them, is the treatment goals that we all know of. It's maximally and durable suppression of the HIV, RNA, restore and preserve the immunological function, reduce the HIV morbidity, and prolong life, and decrease mortality, and prevention of transmission. This is all we do it based on the selection of the initial combination regimen that fit our patient and improving adherence. So if you have both of them, you will get the good results. And these are the basic, just remember them when I finish from the case. So how you predict your virological success if you have all these elements all at the same time. Low, baseline viremia, that's when they present. High potency of our regimen, and we have a lot of good medication currently. Tolerability of the regimen, the convenience, and I know that everybody looks for one tablet regimen at all time, and excellent adherence from the patient side. So going to our patient, he's a 62-year-old Bahraini who's receiving first-line treatment as per the guidelines. I know that's a lot of change, and we are planning Bahrain to change them. So he's been taking Jumvoya for 3 years. His virologically suppressed. His last CD4 count was March 2020 with 365. Taking consideration that his presentation was in August, and during that time in Bahrain, part of the whole pandemic, we shifted our patients to telemedicine. So we have appointments just, by calling them, checking, and, there was little, decreased number of people attending to get their labs. So last one was in March. He attended in August with his presentation. He's a known case of diabetes, also hypertension and dyslipidemia, taking the consideration of his age. Presented to our accident emergency department, the history of fever for 1 week, responded to paracetamol, history of productive cough for 1 week, shortness of breath, history of loose motion, lasted for 1 week, 3 to 5 times per day. And this is the usual cases that we present, and usually it's within the first week of getting the COVID-19. Patient denied any history of runny nose, headache, chest pain, vomiting, abdominal pain, and on examination, he was not maintaining a good saturation of room air. He required oxygen at 5 liters and a febrile at that time with a good vitals. He's was conscious, alert, oriented to time, place, not dizzy on examination. Chest examination were good, and chest X-ray showed a bilateral infiltrated, kind of typical cases. So his patient was started, and this is where it come and really hit us, how to treat. And I'm talking August. Now probably we have better image with certain guidelines came in the picture, but that, in August, when, people started to get all the countries, the cases. So we started an antibiotic and the triple therapy. At that stage in Bahrain and probably other countries, we are using the triple therapy for treating, which is ribavirin, leponavir, ritonavir, and interferon. Plus, we were getting the heparin on board and also the steroids. So radiology, part of our protocol of treatment of COVID-19, to do an echocardiogram, and it was done. His heparin increased to treatment dose, because this was our protocol, starting dexamethasone with the hypoxia, and his controlled sugar with the insulin, because that was the time that not to keep metformin, because of the drug interaction, and his medication were adjusted to his kidney function. He actually did really kind of not bad, because most of our patients, when they get really hypoxic, we try to maintain them in non-invasive ventilator and not to get to intubation. And actually he did well, except for agitation and started to have depression. And if you dealt with COVID-19, especially those patients who needed oxygen to be admitted under critical care, it was very common to be agitated and depressed. And that's where we had to start some medication discussion with drug interaction. That's where the ID consultation came on board. So over the next 9 days, actually, he stabilized, his oxygen started to improve and his kidney function, and he was discharged. He has a total admission in the institution for 14 days. So this is his X-ray on admission with the typical bilateral ground glass appearance. And, it gets worse till it little bit gets better, because it takes time. This is example of his lab, but this is not the whole labs. But with COVID-19, we measure certain biomarkers. I'm sure most of the centers, they measure the same thing: LDH, D-dimer, procalcitonin, C-reactive protein, IL-6, just to make sure where our patient is heading. Is it worse, is getting worse or bad? So we are following him closely. This is the medication list. This is very important when it comes, because it came the question, you're using this medication, he's doing very well. Should we switch to another drug? Should we stop it right now or continue? So with all these medication in the picture, we try to revise them. So this is a kind of updated kind with the, the elvitegravir combination drug, what we can use or not. So he was in a lot of these medication. And if you see that most of them are okay, But, you know, we have a couple of questions about, for example, if you go for dexamethasone, which is questioned in HIV in general, but, you know, we kept because, you know, the course of dexamethasone use in HIV COVID-19 in 10 days. So we said, you know, we'll go with it, keep the same medication. Actually, we didn't have much alternative for this patient at that time. So we had really a lot. So a couple of points about those, you know, points that, you know, we were facing with this case. The steroid and HIV, probably if you are treating HIV, you know that oral steroid or even non-oral, they can interfere with the HIV medication, and actually they can really modify their level in the blood. So, you know, COVID-19 will not be an exception. The only one thing is that it is for 10 days and we stop it later on. So that's where we take it in consideration. So the general recommendation actually for treatment COVID-19 and HIV, it has to be the same. It's the same as general population. So your triage protocol in your country, your treatment protocol COVID-19 should be the same, and you should start the same thing. The only one thing, and this is where the infectious disease or the HIV physician has to come in the picture, is the drug-drug interaction. For example, I'll go on several. Remdesivir, is it okay to start? Yes, according to the guideline. Yes, you can use it with your most antiretroviral medication. The dexamethasone, we said that, we mentioned that, and because it's 10 days, so we can go ahead and give it to the patient. The other part is the immunomodulator. I'm sure, you know, you heard about a lot of biological agents that we used for treating COVID-19. And in Bahrain, actually, we used a couple of them, which really not impressed, you know, myself, you know, and even like our Bahrain experience with the result of those biological agents, but they were there and we used them. And I think they deserve to be used in HIV patient, and they are not exception to the rule. The other thing we mentioned about the other antiretroviral medication, I mentioned leperenvir, ritonavir, but I know that others has been tested and actually under study to be used as COVID-19 treatment. So that was the treatment, you know, whether the question we are starting, you know, for them Kaletra, do you need to stop it or keep both at the same time? So actually, we didn't stop the primary, you know, the drug of choice that he was taking, but we kept Kaletra for a couple of days and he received it. And when we see the QT prolongation, we just withheld the Kaletra. So we're waiting for more studies in that part, whether those HIV medication can be used as anti-COVID-19. The other thing, the other investigational medication, you know, we know as of now, and I'm talking, you know, we're talking now, not back in August, there's no drug, no actual cure and medication that you can use for COVID-19. All of them are investigation, and HIV, as per the guidelines, you can use them and take them. The other very important point is that when he needed tube feeding, what you will do, are you crushing? You have, you know, solution like, you know, the formula for all the medication. Yes, we don't have them, and sometimes we have to crush some of the medication, and they're, you know, whether they will work or not work. If you have a COVID-19 patient and at the same time it's a new case of HIV, what to do? When to start ART, I think is still unknown. You know, this is where probably has to be dealt probably as an acute infection until the patient is stabilized. The other point, which is very important, not to forget that those patients can present with other opportunistic infections. So having COVID-19 does not mean they will not have anything else. Actually, we have another patient who had COVID-19 and TB at the same time. The other thing is that, you know, switching has to be made with the specialist, not to be done by, I know that most of these cases complicated are done by chest physician, pulmonary or ICU physician, but has to be ID on board to assist this patient. The last point here in this slide, their opportunity, our HIV patient, to be part of the clinical trials. And you know that there are a lot of clinical trials in medication and in vaccine. And I know as in vaccine, for example, the trial that has been done in Bahrain, we were excluding the HIV patients, and that's per the protocol of the study. But I think, and even by the protocol available and the, you know, recommendation internationally, they have to be part of it. As I mentioned, the specialist has to be there on board for anything, not to switch or adjust. You don't have to, especially if the patient is controlled. And, you know, if the case is new, please, you know, discuss with the ID what's the option for the patient. This slide actually summarizes what I said. If you have COVID-19 and HIV, what to do for COVID-19 and what to do for HIV. One thing is interesting is that the new guidance about what will be the best for probably, as anti-HIV for treating, HIV and COVID-19, probably the Biktarvy, which is the new, combination. And it's good because I think the main issue is the less drug-drug interaction. And that's what we are looking. And actually they mention also in their guidelines, which we just issued, I think like once October 2020, just recent, is that monitoring is good, do it as usual, look for drug-drug interaction, don't switch unless it's absolutely necessary. Look, because most of as I mentioned also earlier, that most of our medication within the COVID-19 is really short courses, so you can maintain the same drug even if you are worried about drug-drug interaction. Really make sure that you have a good supply for HIV medication. I know what's happening in the whole world. The travel and the supply for everything was really questionable. So make sure that you have maintenance at least 6 months of all medication for HIV. If you have an access when you start, if you want to start in treatment with a new HIV case, you have to know your baseline resistance as usual, follow-up appointment, do the test for the patient, what's needed for the medication, and give a good advice for them. The other part is that, as we said, continue giving the medication, don't stop them, avoid drug substitution, and critically ill patient, you have to look for what other formulation that can be given through the tube feeding. So my take-home message here, point from this case, and this patient actually after his discharge, he is supposed to come next week, December, as a follow-up with his old medication. We adjusted his medication and actually we received the Biktarvy. So that's why I mentioned the guidelines, because we switched him to that medication and tried to look for the drug interaction. We started him an antidepressant, still actually depressed. And I think one major point about COVID-19 is the long-term impact. And there are a lot of studies that say even after recovery, even if it was mild case, we have cardiac, we have coagulation, we have neurological complications, psychological complication after the COVID-19. So that has to be taken into consideration. Consider the drug-drug interaction, the food requirement as we do usually, but it's quite complicated here because there's a lot of investigational drug on board, and all the treatment recommendation, please, has to be run by your infectious disease consultation. So at the end, I can say how much we know about COVID-19 is still, I think, is the tip of the iceberg. We're trying our best, but the knowledge is expanding, and we need more actually to know how to really adjust our medication treatment for our HIV patient. And thank you very much for listening. Thanks.
Thank you very much, Dr. Jamila, for this very interesting case and presentation on the interaction between HIV and COVID-19. I think we had several questions. I'd like to thank the attendees who sent in their questions specifically about the interaction or the co-infection COVID-19 and HIV, and I think you've answered a lot of those, and I think that you made the point, a lot of points about that. Can you, so but there is there was a question, so we still have 8 more minutes, so I'd like to use this time to basically go, well, thank you, Dr. Jamila, again, and the attendees. And I think, again, as I said, most of our questions were, the questions here were answered. The issue about susceptibility or vulnerability of people living with HIV to COVID-19. Would you like to comment on that, Dr. Jamila?
Thank you. Thank you. I think this is very important because even at the beginning of the pandemic, we were looking as COVID-19 a disease of the immunosuppressed, like any disease, like any infectious disease. That's correct. But what we saw, and this is the experience of the whole world, is that, yes, our immunosuppressed patient at higher risk of getting it, yes, and complication. But on the other hand, who are at higher risk of getting the disease and complication are the others. Basically who? Obesity, the hypertension, hyperlipidemia, okay, and diabetes. These are the 3-4 top risk factor. And if you see all the guidelines actually count them So if you have one, your risk is so, like for example, double or triple if you have 2 or 3. Even by CDC, even our experience in Bahrain, our data, we saw that. And from the cases, I think we have 5 cases of HIV with COVID-19 in Bahrain. They did very well. I'm not sure what. And we have patients who are oncology, active oncology cases receiving chemotherapy, they recovered. We have people transplant, they are recovered. Our death, and this is our analysis in Bahrain, and I think the other data, the mortality rate were on the top dose risk factor, diabetes, obesity, hyperlipidemia, and it's not HIV or other immunosuppressive drug or even disease. And that's amazing. It's a metabolic. It really hits all the body, and it's associated with our metabolic. How well is our body?
Okay. So this is good. There was another question from Hassan Taraif to Dr. Jamila about the availability of HIV medication in Bahrain. Is this affected by the epidemic? And do you advise people living with HIV to take the COVID-19 vaccination? So
thank you.
I know. Yeah. What do you think?
Very intelligent question. Yes, the first one, it didn't affect, exactly, in Bahrain, I think, probably somebody heard about our planning was ahead of time, everything is ahead of time. If we get to like supply of one medication, that's the usual even before the pandemic. It's just, logistic or anything, but nothing really affected in our supply in medication or PPE in Bahrain. Actually, we have more than what we need in general. That's the one part. The other part, taking the vaccination. Yes, I'm a big advocate of taking the vaccine. And I can tell you that in Bahrain, we have approved 2 vaccines so far. We have approved the Pfizer as emergency use. We have approved the Chinese Sinopharm. And now we have a full authorization for Chinese. And by the way, I took my 2 vaccines. I'm done with the 2 shots. So, that's it. And I advise my patient for taking it. If you'll go for the contraindication, as per the CDC update, was for Pfizer, and actually maybe it will go for Moderna. Now they approved it just yesterday. That will be for it. So what's the exclusion? What's the contraindication? It's basically if you have severely immunosuppressed patient who had active and severe disease currently, but if you are stable, you are controlled, and you have good immune system, yes, you can take it. And why I mentioned the Chinese versus Pfizer, because the Sinopharm is inactivated vaccine. I know our HIV patient can take the inactivated vaccine. So yes, you can take it. And I think it's very important to really comply with it. That's where we will probably has a light at the end of the tunnel. We need this vaccine because this is the only way of dealing with COVID-19.
Excellent. So this is great. We have another question about any association between COVID-19 infection and HIV treatment failure in patients already on treatment. I don't think so.
No,
I mean,
yeah.
Personally, most of the patients, the people living with HIV whom I follow in clinic, and who had COVID-19, and I think that's probably more than 20 different persons, 20 to 30. The symptoms have been mild, and none of them has been hospitalized. So it's fairly. I think the risk factors for COVID-19, if they're there, then yes. But for otherwise, a non-obese, no cardiovascular disease, no underlying diabetes or cardiac disease, hypertension, it's a good. And there's definitely no interaction between COVID-19 infection inducing treatment failure or causing treatment failure in patients living with HIV, because as we said, if you're going to give Dexa, that's for a finite period of time, it's 10 days. If you're going to use remdesivir, that's also for 5 days, and there are no drug-drug interactions anyway. The other antibiotics are relatively safe and with no interactions if one has to do that. So this is it. So these are all the questions we had here. We've answered most of them, and we've also have a thank you to Sarah for her excellent work and talk, and we're all very impressed and happy with the MERSA's response to the pandemic and the financial disaster. And we hope that at the next, because we're planning to have these sessions on a monthly basis, now with the support of the IAS, and hopefully in the future, we can continue to provide this space to exchange ideas, expertise on anything related to HIV. So I would like to encourage the participants, the attendees, to go ahead and send us their questions, their suggestions to the Q&A or by email to the email provided earlier. And to also think about if they would like to participate. We will have another session next month, I think. So any viewpoint or any experience from any part of this MENA region is really very welcome. And the recordings are available, will be available on the IAS website very soon. So we will also let you know. And the PowerPoint presentations will also be shared. So thank you again for participating in attending our virtual meeting. Thank you to my co-host, Dr. Arash, the presenters, Dr. Jamila, Sarah from Beirut, and Marsa. And thanks to the IAS, the great IAS support team. Great work by Radka and Loran. Thank you so much for helping us and supporting us here. And looking forward to seeing everyone, hopefully all of you attendees and participants in the next month after the new year. So happy new year, everyone. Stay safe, be careful, take care of yourselves. We'll see you in January. Thank you and bye.